Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. So usually, when we talk about a medical diagnosis, there's this expectation of precision. It feels almost like engineering, right?
Right, very clinical.
Yeah, like you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, well, there it is, broken.
Exactly.
It's clean, it's visible.
It's entirely binary. And as humans, we crave that. We really like our health data to be categorized with absolute, undeniable certainty right from the start.
But then you step into the world of maternal newborn nursing, you step into the early stages of pregnancy, and certainly that metaphorical x-ray machine is just completely useless.
Oh, completely.
We aren't looking at a clear diagnostic picture anymore. We are navigating a physiological landscape that is, well, it's incredibly murky.
I think diagnostic muddy waters is the perfect way to describe it, because in those first few weeks and months, a woman's body is undergoing this massive systemic transformation. And the trick is, many of the symptoms of that transformation look exactly like a dozen other totally unrelated health conditions.
Which is exactly why we are taking this deep dive today. So if you are listening to this right now, we know exactly who you are.
We do.
You are a nursing student. You're probably staring down a massive maternal newborn exam, or maybe you're prepping for your clinical rotations, and you are feeling the intense pressure of trying to memorize thousands of isolated facts.
It's a lot. It really is.
It is. So take a deep breath. We're the Last Minute Lecture team, and we have a very specific mission for this deep dive. We are taking the foundational text, specifically focusing on Chapter 14, Nursing Care of the Family During Pregnancy. Right. And we're going to translate all of that dense physiology into practical clinical reasoning.
And we're going to do it by connecting the what to the why. Because when you just try to memorize lists of symptoms or warning signs, they honestly just fall out of your head the second the exam is over.
Oh, instantly. Gone.
Right. But when you understand the underlying mechanical and hormonal and, psychological reasons for why a symptom is happening, you never have to memorize it again. You just know it.
Because it makes logical sense.
Exactly. That is how you conquer your exams. And far more importantly, that is how you become a safe, brilliant nurse at the bedside.
Because prenatal care isn't just about taking a blood pressure and handing a patient a pamphlet on eating leafy greens.
No, not at all.
It is this profound, fleeting window of time. The assessments you make, the education you provide, and the tiny red flags you catch during these 40 weeks can literally shape the health trajectories in 2 entire generations at once.
It's an awesome responsibility. You aren't just managing a medical event. You're managing a major maturational crisis and a complete physiological overhaul.
So let's start right at the beginning of the patient's journey. A patient walks to your clinic, she sits down, looks at you, and says, I think I'm pregnant.
Okay, the classic opening.
Right, so how do we actually definitively confirm that? The clinical framework divides the signs of pregnancy into 3 very strict categories. You have presumptive, probable, and positive.
Yes.
Let's really pull these apart, because the distinction between them is like the absolute core of early clinical reasoning.
The secret to mastering these 3 categories is really looking at 2 variables. Who is experiencing the sign, and what else could possibly be causing it?
Okay, who and what else?
Right. So let's start with the lowest tier, which is presumptive signs. These are purely subjective. These are the physical changes felt and reported by the woman herself.
Right. So she comes in and tells you, I missed my period, which, we chart as amenorrhea.
Yeah.
Or she says, I am bone tired, I'm exhausted.
Or my breasts feel incredibly tender.
Exactly. Or I'm throwing up every morning. And maybe if she's a little further along, say around 16 to 20 weeks, she says, I feel the baby fluttering. And that fluttering is called quickening.
Yes, quickening. Now, why are these only labeled presumptive? Why can't a provider just diagnose a pregnancy based on a missed period and severe morning nausea?
Because life happens. Bodies are complicated.
Exactly. If we zoom out and look at human physiology as a whole, we know that severe psychological stress or rigorous athletic training or malnutrition...
Or endocrine disorders, right, like thyroid issues.
Yes, thyroid issues can easily cause amenorrhea. And what about the nausea and vomiting?
That could literally just be a gastrointestinal virus or food poisoning.
Right. And extreme fatigue is a symptom of almost every illness known to humanity.
Wait, what about the quickening? The fluttering in the stomach? If a woman feels what she believes is a baby moving, how is that not proof?
Well, because the human intestinal tract is constantly moving.
Oh, like digestion.
Exactly. Normal peristalsis or even just trapped gas moving through the bowel can mimic the sensation of a tiny fetal flutter perfectly. Yeah. The patient is reporting what she feels, but a nurse cannot chart a definitive medical diagnosis based on intestinal gas that just happens to feel like a baby.
Okay, that makes sense.
Oh, okay.
So presumptive is the patient saying, I feel pregnant based on my symptoms.
Yeah.
But we have to elevate our assessment. We move to the next tier, which is probable signs.
So probable signs shift the focus from the patient's subjective feelings to the examiner's objective findings.
The nurse or doctor.
Right. These are physical changes observed or perceived by a trained healthcare provider during an exam. They strongly suggest pregnancy, but there's a major catch. We still do not have 100% proof.
Okay, and the literature highlights 3 very specific physiological signs here that always seem to trip students up. We have the Goodell sign, the Chadwick sign, and the Hagar sign.
Yes, the classic trio.
To me, honestly, these just sound like the names of a very prestigious law firm.
Yeah.
Goodell, Chadwick, and Hagar. Let's demystify them. Let's start with the Goodell sign, which shows up around 5 weeks. What is the actual mechanism here?
So the Goodell sign is a dramatic change in the texture of the cervix. If you were to palpate a non-pregnant cervix, it feels quite firm, cartilaginous. It feels very much like the tip of your nose.
Okay, touching my nose right now. Firm.
Right. But when a pregnancy implants, there's an immediate rush of hormones, estrogen and progesterone. And those cause massive increased vascularity, slight hypertrophy, and hypoplasia in the cervical tissue.
And hyperplasia meaning like an increase in the number of cells.
Correct. More cells, more blood flow, more fluid. As a result, the cervix becomes remarkably soft. Instead of feeling like the tip of your nose, it softens to feel more like the texture of your lips.
Oh, that's a great physical anchor. Firm nose becomes soft lips.
Exactly. The examiner feels this distinct softening during a bimanual pelvic exam. That is the Goodell sign.
Okay, what about the Chadwick sign? That one usually appears around 6 to 8 weeks, right?
Right. So while Goodell is about touch and texture, the Chadwick sign is purely visual. It's a violet-bluish discoloration of the vaginal mucosa and the cervix.
Because of the blood flow again.
Entirely driven by that massive increase in vascularity and blood pooling in the pelvic organs to support the uterus, the tissue literally changes color to a bluish purple.
And then we have the Hagar sign, which is usually noted between 6 and 12 weeks.
The Hagar sign is fascinating. It's the softening and compressibility of the lower uterine segment.
Compressibility meaning you can actually squeeze it.
Basically, yes. During a bimanual exam, the provider places 2 fingers in the vagina and the other hand on the abdomen, and they can feel that the very lower part of the uterus has become remarkably soft and compressible.
Wow.
So soft, in fact, that it almost feels as if the firm cervix and the firm upper body of the uterus are 2 completely separate organs.
Okay, so Goodell is a soft cervix. Chadwick is a blue-violet discoloration.
Yeah.
Hagar is a soft, compressible lower uterus. But here's where I really have to push back.
Okay, go for it.
Under probable signs, the clinical framework also includes positive pregnancy tests, both the urine tests you take at home and the serum blood tests done in a lab.
Yes, it does.
If I go to the pharmacy, take a test, and 2 pink lines appear, I am immediately calling my mother to tell her I'm pregnant. Why on earth is a positive test only considered probable in a clinical setting?
It's a brilliant question, and grasping this distinction is vital for clinical safety. Pregnancy tests do not detect a baby. They detect a hormone.
Right, HCG or human chorionic gonadotropin.
Exactly. And usually, yes, it's produced by the trophoblast cells that eventually form the placenta.
Yeah.
But here is the critical physiological caveat. A positive HCG result can, very rarely, be caused by things other than a healthy, developing fetus.
Like what?
For example, certain types of pelvic or ovarian tumors secrete HCG.
Wait, really? So a tumor could trick a pregnancy test?
Yes. Or consider a hydatidiform mole, which is also known as a molar pregnancy.
I've heard of that, but what actually is it?
It's a severe chromosomal abnormality. Basically, a sperm fertilizes an empty egg. Or 2 sperm fertilize 1 egg. a viable fetus never forms. But the tissue that was supposed to become the placenta grows wildly out of control into this mass of fluid-filled cysts inside the uterus.
Why?
And this mass pumps out massive skyrocketing levels of HCG. So the woman will have severe pregnancy symptoms. She'll have a wildly positive pregnancy test, and she might even show the Goodell and Chadwick signs due to all those hormones. But there is no baby.
That is terrifying.
Yeah.
But it perfectly explains why we cannot rely on a chemical test as absolute proof. We are testing for a hormone, not a human.
Precisely.
That's one more probable sign, right? Ballotmal, noted around 16 to 28 weeks.
Right, Bellamo. This is an examination technique. The provider taps the cervix gently during a vaginal exam. If a fetus is present, it will float upward in the amniotic fluid and then a second later, rebound, falling back down to tap gently against the examiner's finger.
You feel like a subtle fluid bounce.
Exactly. But again, if a woman had a very specific type of, say, pedunculated uterine polyp floating in fluid, it could theoretically mimic that bounce.
Okay, so to summarize our diagnostic tiers, presumptive is the patient feeling symptoms that could just be the flu or stress.
Right.
Probable is the provider observing profound physical and hormonal changes, but acknowledging that tumors or molar pregnancies could fake those changes. Which finally brings us to the ultimate tier, positive signs.
Positive signs provide absolute, undeniable confirmation. They can be attributed to only one thing, which is the literal presence of a fetus. There are no alternate physiological explanations.
And these are exactly what you would logically expect, right? Visualization of the fetus by a real-time ultrasound.
Yeah.
Hearing the fetal heart tones, the FHTs, detected by a Doppler or a stethoscope, or fetal movements that are actively palpated or visibly seen by the trained examiner.
Precisely. You see the baby on the screen, you hear the baby's distinct heartbeat separate from the mother's, or you literally feel the baby kick your hand. That is absolute proof. A cluster of cysts or intestinal gas cannot fake a fetal heartbeat on an ultrasound monitor.
All right, so we've run the diagnostics. We have absolute proof she is pregnant. The very next question out of her mouth without fail is going to be, well, when is the baby due?
Oh, always. Every time.
And accurate dating isn't just for, planning the baby shower. It's the linchpin of clinical care, right?
It is the absolute foundation. Accurate dating drives the entire timeline for prenatal screening. It tells us exactly when to draw specific genetic labs. It allows us to track if the fetus is growing appropriately.
If we don't know the accurate due date,
we have no idea if a baby is dangerously premature or dangerously post-term later down the line. It's crucial.
The standard of care notes that an ultrasound in the first trimester is technically the most accurate method for establishing the estimated date of birth, or EDB.
Yes, clinically, we rely on that early ultrasound.
But if you are a nursing student, you are absolutely 100% going to be tested on the manual calculation method, the Nagel rule.
Yes, you will. You will see this on exams, and you'll use it in clinics. And I want you, the listener, to mentally apply this rule right now as we talk through it. Don't just passively listen. Actively do the math with us.
Okay, the Nagel rule is based on the woman's accurate recall of the first day of her last menstrual period, her LMP.
Right, and it assumes a standard 28-day cycle with fertilization occurring on day 14.
So what's the formula?
Here is the formula you must memorize. You take the first day of the LMP, you subtract 3 months, you had 7 days, and you add 1 year.
Subtract 3 months, add 7 days, add 1 year. Let's start with a straightforward example.
Okay.
Let's say a patient comes in, and the first day of her last menstrual period was October 15th, 2024. Listener, try to do this with me.
Go step by step.
Step 1, we subtract 3 months from October. Okay, October.
Yeah.
September, August, July. We are in July. Step 2, we add 7 days to the 15th. 15 plus 7 is 22, so July 22nd.
Yes.
Step 3, we add 1 year to 2024, making it 2025.
Yeah.
So her estimated date of birth is July 22nd, 2025.
Perfect. That is the clean, easy version. But exams love to test you on dates that force you to cross over month boundaries or deal with the calendar year differently.
Oh, doing date math under exam pressure is like trying to defuse a bomb.
It really is. So let's try a trickier one. Let's say her LMP was May 28th, 2024.
Okay. May 28th, 2024. Step 1, subtract 3 months from May.
Yeah.
April, March, February. We are at February 20th.
Good. Now step 2.
Add 7 days to the 20th.
Yeah.
Okay, well, February usually only has 28 days. So if I add 7 days, I'm rolling over into the next month. That pushes me into March. 7 days into March is March 7th.
Exactly.
Now, step 3, add 1 year. But wait, I'm already in the next calendar year because my LMP was in May and my due date is before that in the calendar.
And you're hitting on the exact trap students fall into. When you subtract 3 months from May, you are mentally jumping back into the previous calendar year.
Oh, right.
So if the LMP is May 2024, subtracting 3 months puts you in February 2024. Adding a year brings you back to 2025. Your final answer is March 7th, 2025.
Okay, so you have to be incredibly careful with how the months roll over. Now, in the real world, clinics often use a gestational wheel, right? You just line up the arrows on a little plastic dial, and it does the math instantly.
Oh, absolutely. Or they just type it into the electronic health record and the computer spits out the date. But for your boards, you are the computer. Memorize that formula.
Right.
And as a clinical side note, you should always remind your patients that only about 5% of women actually give birth spontaneously on their exact EDB.
Just 5%.
Yeah. The date is a target, but normal birth happens within a window of 7 days before to 7 days after that target.
All right, so we know she is pregnant, and we know exactly when she is due. This is the moment where our nursing perspective really has to widen dramatically.
Yes.
We have to move beyond just the uterus and look at the human being and the family sitting right in front of us. Let's talk about the psychosocial adaptation to pregnancy.
This is a massive maturational crisis because pregnancy doesn't just reshape a woman's body, it fundamentally alters her identity, her relationships, and her place in society.
The literature references the pioneering work of Reva Rubin, who mapped out maternal role attainment. She described this as a complex cognitive and social process moving through 3 distinct phases. Let's walk through those. Phase 1 is accepting the biologic fact of pregnancy.
Right. So in phase 1, the woman's thoughts are intensely focused on herself and the reality of her changing physical state. She might be dealing with the shock of a positive test, the misery of morning sickness, or just that profound early fatigue.
So her internal monologue is basically, I am pregnant.
Exactly. I am pregnant. At this stage, the fetus is viewed as a part of herself, not as a separate, distinct human being.
Which makes complete psychological sense for the first trimester. I mean, you are just trying to survive the nausea. You aren't really conceptualizing a separate person yet. What triggers phase 2?
Phase 2 usually occurs around the 5th month, and it is heavily driven by physical evidence. Specifically, feeling the baby move, that quickening we talked about, or hearing the heartbeat clearly.
And what happens then?
The woman begins to accept the growing fetus as distinct from herself. Her internal monologue shifts from, I am pregnant, to, I am going to have a baby.
That differentiation is huge.
It's the bedrock of attachment. It marks the beginning of the mother-child relationship, which involves a really deep sense of caring and responsibility. She often becomes much more introspective during this phase.
Introspective how?
Well, she might withdraw slightly from her usual social circles, just to concentrate her emotional energy on this newly perceived separate little being inside her.
And then phase 3 is preparing realistically for birth and parenting.
Yes. The thought process evolves again to, I am going to be a mother. She might start speculating on the baby's personality traits based on how vigorously they kick. She begins organizing the nursery, reading parenting books, and actively seeking out information on labor.
Now, throughout all of these phases, there is a psychological phenomenon that I think is so crucial for nurses to normalize for their patients, and that is profound emotional ability and ambivalence.
Oh, it is so vital to validate this because despite a general feeling of happiness, many women are completely shocked by their own rapid, unpredictable mood swings.
They just feel out of control.
Exactly. They might experience tears, sudden anger, or overwhelming joy with almost zero provocation.
Which is largely driven by the massive hormonal storm, right?
Hormones play a huge role, sure.
Yeah.
But we cannot discount the very real psychological weight. They are facing immense lifestyle changes, potential career interruptions, financial stress, and let's be honest, the sheer terror of giving birth.
Right. And that leads to ambivalence, meaning having conflicting feelings simultaneously.
Yes.
So a patient might feel thrilled that she's finally pregnant, but at the exact same time, she might mourn the loss of her current independent lifestyle. She might resent her changing body. If I have a patient who says, I wanted this baby, but right now I kind of hate being pregnant, is that okay?
It is entirely 100% normal. Ambivalence is a standard expected finding in early pregnancy. However, this raises a crucial point for your clinical reasoning as a nurse.
Okay, what's the catch?
While ambivalence is normal in the first trimester, if you assess intense, unresolved ambivalence that continues deep into the 3rd trimester, that becomes a major clinical red flag.
Why? What does late-stage ambivalence tell the nurse?
It indicates a severe unresolved conflict with the maternal role. If she's 36 weeks pregnant and still deeply resenting the pregnancy, completely detached, or hasn't mentally progressed to phase 3, the I'm going to be a mother phase, she is at high risk.
Risk for what?
She may need significant psychosocial support, counseling, or psychiatric intervention to ensure she is emotionally prepared to bond with and safely care for that infant after birth. You simply cannot ignore late ambivalence.
That is a really powerful distinction. Now, the mother isn't the only one adapting. Let's look at the partner's adaptation.
Yes, the partner's journey is also complex.
The framework outlines May's 3 phases for the expectant father or non-pregnant partner: the announcement phase, the moratorium phase, and the focusing phase. The announcement phase sounds identical to the mother's phase 1, right? They're accepting the biological reality, dealing with initial joy, shock, or ambivalence.
Right.
But I really want to dissect this second phase, the moratorium phase.
Let's unpack it, because it's frequently misunderstood by both partners and nurses.
The literature states that during the moratorium phase, the partner accepts the reality, but they often become highly introspective. They start having deep internal debates about their philosophy of life, their own relationship with their parents, their religion, their career trajectory. They kind of just pull back to think.
Yes.
I have to say, if I am throwing up every morning and feeling exhausted, and my partner just mentally checks out to ponder the meaning of the universe, I'm going to feel completely abandoned.
Most people would.
If a nurse observes a partner who seems quiet, withdrawn, and distant during a prenatal visit, is that a red flag for neglect or a bad relationship?
You're hitting on the exact friction point that causes so many arguments in early pregnancy. But clinically speaking, no, it is generally not a red flag. What's fascinating here, and what you as the nurse need to explain to the couple, is that this introspection is a deeply healthy, necessary psychological defense mechanism.
How so? Because it looks like they're just ignoring the situation.
Think about it from their perspective. The non-pregnant partner does not have the constant visceral physical reminders of the pregnancy that the mother has. They aren't feeling the nausea. They aren't feeling the uterus stretch. The moratorium is their necessary psychological space to process the massive, life-altering responsibility that is rapidly approaching. They're fundamentally reevaluating who they are in the world to prepare for the role of provider and protector. They aren't ignoring the mother habit. They're trying to build the psychological scaffolding required to be a good parent. It's preparation, not neglect.
Wow. If a nurse can explain that to a frustrated pregnant patient, you might literally save a relationship. You reframe their withdrawal from checking out to gearing up.
Exactly. And eventually they move into the focusing phase, where they actively negotiate their role for labor and parenthood. They want to know the hospital route, what the fetal monitors do, and exactly how they can physically support the mother during contractions.
It is also paramount that we discuss adaptation for LGBTQIA couples. The clinical standard is very clear. Nurses must actively avoid heteronormative attitudes.
This is non-negotiable. The non-pregnant partner in a same-sex couple is going to experience the exact same fears, the same questions, and the same moratorium phases we just discussed.
But they often face a heavy added layer of stress, don't they?
Absolutely. A lack of recognition, exclusion, or outright discrimination from society, their own families, or unfortunately, even healthcare providers.
I can't imagine how stressful it is to be worried about a pregnancy and also have to constantly advocate for your right to even be in the exam room.
It's deeply traumatic. The nurse's role is to immediately dismantle that barrier. You create a gender-affirming, actively supportive environment. You use respectful, chosen terminology. You establish rapport, and you ensure the non-pregnant partner is not just permitted in the room, but actively included in all decision-making and activities the couple desires.
Let's widen the lens even further to the siblings. How do we assess their adaptation? Because bringing a new baby into a house completely shatters the existing hierarchy. The developmental response really depends on their age, doesn't it?
Completely. A 1-year-old is largely oblivious until the baby actually arrives, but a 2-year-old toddler, that is a very vulnerable age for this transition.
Why toddlers specifically?
Toddlers fundamentally require sameness in their environment to feel secure. A rapidly growing pregnant belly, a mother who is suddenly too tired to carry them, and a house filling up with strange baby gear disrupts that required sameness.
So you might see acting out.
You'll likely see clinging behavior, tantrums, or regression. A toddler who is perfectly toilet trained might suddenly start having accidents. A child who slept through the night might start waking up screaming.
So as the nurse, Your intervention is anticipatory guidance. You teach the parents that this regression is not bad behavior. It's an acute stress response.
Right. You advise them not to punish the accidents, but to offer extra reassurance.
What about slightly older kids, like the 3 to 4-year-olds?
Preschoolers are intensely fascinated by their own beginnings. They want to know the mechanics. They love hearing the fetal heartbeat with a Doppler. They love feeling the baby kick. And school-aged children take an almost clinical scientific interest.
Like, how is the baby breathing in water?
Exactly. How is the baby eating in there? Exactly how is it getting out? They generally enjoy feeling helpful, like organizing the diapers or picking out clothes.
And finally, the grandparents.
Yeah.
They are usually thrilled stepping into the role of family historians, but the literature notes that some might actually react negatively.
Because a grandchild is undeniable, biological proof that they are aging. It forces them to confront their own mortality. This can lead to resentment or detachment, which can inadvertently crush the self-esteem of the expectant parents who are hoping for joyous support.
The core takeaway here is that the nurse must view the entire family unit as the client. You assess all these dynamics so you can tailor your psychosocial support effectively.
Exactly.
Okay, so we have diagnosed the pregnancy, we've dated it, and we understand the psychological storm the family is navigating. Let's shift into the logistics of care. How do we actually structure all this medical management to optimize outcomes?
Let's start with the overarching models of care. The traditional prenatal schedule has been the standard for nearly a century. An initial intake visit in the first trimester, then brief monthly visits until 28 weeks, biweekly visits until 36 weeks, and weekly visits until birth.
But there is a shift happening, right?
Yeah.
The evidence-based practice highlights group prenatal care, specifically models like centering pregnancy. This fascinates me.
It's a wonderful model.
Instead of sitting in a waiting room for an hour just to get 10 rushed minutes alone with an obstetrician, women with similar due dates are grouped together.
Yes. They arrive and they're empowered to take their own weight and blood pressure. They have a very brief private abdominal check with the provider in the corner of the room, and then the real magic happens.
The group session.
Right. They spend an hour and a half to 2 hours in a facilitated group discussion. They talk about nutrition, stress, labor expectations, and newborn care together.
And the data on this is staggering, isn't it?
The clinical outcomes are remarkable. Group care is statistically associated with a decreased incidence of preterm births, fewer low birth weight infants, lower NICU admission rates, and significantly higher rates of breastfeeding initiation.
Why? I mean, it's the exact same medical information being delivered.
Because it treats the social determinants of health, it shatters isolation, it creates a powerful community of mutual support, which drastically lowers maternal stress hormones. This is particularly transformative for individuals in high-stress environments or minority groups facing systemic health disparities.
That is incredible. But regardless of whether a patient chooses a traditional or group model, every single pregnant person goes through the initial visit, the intake.
Oh yes, the big one.
This should ideally occur before 10 weeks, and it is by far the longest, most exhaustive visit of the entire pregnancy.
Because it establishes the absolute baseline. If a patient has a history of preterm labor or an underlying cardiac condition, finding that out at week 8 gives us months to intervene, adjust medications, and consult specialists. Finding it out at week 38 when she shows up in triage could be a catastrophic disaster.
So let's talk about the absolute bedrock of the intake, documenting the obstetric history. If you are a nursing student, your ears should be ringing right now because the NCLEX tests this relentlessly.
It is everywhere on the boards.
We have 2 systems to document this, the 2-digit system, which is gravidaPara, and the 5-digit system, GTPL. Let's define the root words first.
Sure. Gravida simply means a woman who is pregnant. A nulla gravida has never been pregnant. A primigravida is pregnant for the very first time. A multigravida has had 2 or more pregnancies.
Okay, that's straightforward. But parity is where it gets complicated.
Parity is the number of pregnancies in which the fetus or fetuses have reached 20 weeks of gestation. It is crucial to internalize 2 rules here.
Okay, hit me.
Rule 1. Parity is about the pregnancy reaching 20 weeks, not the number of fetuses born. A pregnancy with triplets counts as one single Paris event.
Got it. Twins or triplets, still just one pregnancy.
Right. Rule 2. Parity is not affected by whether the baby is born alive or stillborn. If that pregnancy hit the 20-week mark, it counts toward parity.
Okay, let's break down the GTPL system because this is how you will communicate in the hospital. Let's spell it out.
All right. G stands for gravida, the total number of pregnancies. Including the current one.
Including the current one, okay.
T stands for term the number of pregnancies that ended at 37 weeks or beyond. P stands for preterm the number of pregnancies that ended between 20 weeks and 36 weeks, 6 days.
Okay.
A stands for abortion, the number of pregnancies that ended before 20 weeks, either by spontaneous miscarriage or elective termination. And L stands for living the number of children currently living.
This definitely requires practice. Let's run a few rapid-fire clinical handoff scenarios for the listener to calculate mentally. Scenario 1, a straightforward one. A woman comes in for her intake. She is currently pregnant. She has one child at home who was born right on his due date at 40 weeks. No other history.
Okay, let's walk through it.
Okay, listener, work it out. G, gravida. She is pregnant now, and she had the one previous pregnancy. So G's 2, T, term. She had a one baby at 40 weeks, which is past 37. So T is 1.
Right.
P, preterm is 0. A, abortion is 0. L, living. She has one child at home, so L is 1. Her GTPL is G2, T1, P0, A0, L1. That's the easy one. Hit me with a hard one.
Let's increase the complexity. A patient arrives for her initial visit. She is currently pregnant. You take her history. She tells you her first pregnancy ended in a miscarriage at 10 weeks. Her second pregnancy was a set of twins born prematurely at 34 weeks. Both twins are alive and doing great. Her third pregnancy was a single baby born at 39 weeks. But tragically, that infant died of SIs at 2 months of age.
Oh, wow. Okay, this is the exact kind of trap an exam will set. Let's walk through it meticulously.
Take your time.
Okay, G, gravida. How many times has she had a positive pregnancy that be implanted? She is pregnant now, it's 1. The miscarriage is 2. The twins is 3. The baby who passed away is 4. So G is 4.
Correct.
T, term. Did any pregnancies reach 37 weeks? Yes, the third pregnancy was born at 39 weeks, so T is 1.
Correct. Remember, the fact that the infant later passed away does not change the fact that the pregnancy reached term.
Right. P, preterm. Did any pregnancies end between 20 and 36 weeks? Yes, the twin pregnancy ended at 34 weeks. Now, here is the trick. It was twins, but it was only one pregnancy, so P is 1, not 2.
Excellent. The T and the P always refer to pregnancies, not babies.
A, abortion. Did any end before 20 weeks? Yes, the miscarriage at 10 weeks, so A is 1. And finally, L, living. How many living children does she have right now? She has the twins. The term baby passed away, so L is 2. Final answer, G4, T1, P1, A1, L2.
You nailed it. If you can methodically work through a complex history like that, keeping the definitions strict, you will never miss a GTPL question.
Okay, moving past the obstetric history, the nurse conducts a massive health and psychosocial interview. We ask about past surgeries, underlying medical issues, every medication they take. We also dive deep into mental health. The framework notes that perinatal depression is the most common complication of pregnancy.
It is shockingly prevalent. We routinely use the PHQ-9 questionnaire to screen for depression and anxiety at the initial visit and throughout the pregnancy.
We also have a strict mandate to screen for intimate partner violence, or IPV. The literature notes that IPV occurs in as many as 20% of all pregnancies. The stress of the pregnancy can cause existing abuse to escalate, or it could be the trigger that starts the violence.
It's a highly vulnerable time. But there's a critical, unbreakable procedural rule for the nurse here. IPV screening must be conducted in a safe, private setting with the woman completely alone.
Right. You cannot look at a woman while her partner is sitting right next to her, holding her hand, and ask, "Do you feel safe at home? Is anyone hitting you?"
Never.
If he is an abuser, she will lie out of terror, and you have just put her in immense danger when they leave the clinic.
Exactly. If the partner refuses to leave the room, the nurse must employ clinical tact. You say, "I need to take her down the hall to the lab for a quick urine sample. I'll bring her right back." You get her alone in the bathroom or the lab, and you do the screening there, and it must be assessed at the first visit at least once every trimester and at the postpartum visit, because the risk dynamics change.
Let me push back on this entire interview process. We are asking about deep mental health trauma, sexual history, previous abortions, domestic violence, dietary habits. I mean, how does a nurse ask all of this without sounding like an aggressive interrogator with a clipboard? Are you depressed? Are you abused? How many sexual partners have you had? It sounds incredibly invasive to ask a stranger within 10 minutes of meeting them.
It is deeply invasive. And that is exactly where the rigid science of data collection must yield to the subtle art of nursing. If you just read those questions like a robot, the patient will shut down and lie to you. The goal of the initial interview is not data extraction, it is establishing a therapeutic alliance.
So how do you do that practically?
You start by building psychological safety. You explain why you are asking these things. You say, I'm going to ask you a lot of very personal questions today. I ask every single patient these same questions because pregnancy affects every part of your life, and my only goal is to make sure you and your baby are as safe and healthy as possible. You use an unhurried, sensitive, non-judgmental tone. You look them in the eye, not at your screen.
Setting the stage makes all the difference. Okay, after the interview, we move to the physical exam and vital signs. The clinical guidelines detail a very strict procedure for taking blood pressure. Now, I know nursing students sometimes roll their eyes at BP instructions. They learn how to put on a cuff on day one. But in obstetrics, hypertension can literally be lethal. Preeclampsia is a killer. Precision is everything.
It cannot be overstated. A falsely elevated blood pressure reading could trigger a massive cascade of unnecessary medical interventions, stress, and medications. Conversely, a falsely low reading could mean we miss the early, subtle signs of preeclampsia, leading to maternal seizures or fetal death.
So what are the mechanical rules?
The bladder must be empty. A full bladder causes sympathetic nervous system arousal that spikes BP. She needs a rest period of 3 to 5 minutes before you measure. She must be seated comfortably. And critically, her feet must be flat on a firm surface and her legs must be uncrossed.
Let's dig into that. Why do uncrossed legs matter so much? What is the actual physiology there?
When you cross your legs, you compress the large veins in your legs. This slightly impairs venous return to the heart and increases intrathoracic pressure. The body compensates for this by raising the systolic blood pressure.
Wow.
Yeah, crossing your legs can falsely elevate your systolic reading by up to 10 points. In obstetrics, 10 points is the difference between going home and being admitted to the hospital.
That is fascinating. So feet flat, arms supported at the level of the heart, and you must use the proper size cuff. If you use a cuff that is too small for a patient's arm, it takes more pressure to compress the artery, resulting in a falsely high reading.
Exactly. Next, we draw the routine initial labs. This is a massive panel of blood and urine tests.
Why are we taking so much blood at 8 weeks?
Because we are mapping out hidden risks. We check hemoglobin and hematocrit to establish a baseline for anemia because her blood volume is about to expand massively, which dilutes her red blood cells. We determine her blood type and Rh factor, which is critical for preventing an immune system war later on. We'll dive deep into that shortly. We draw rubella titer.
Rubella is German measles. Why do we care if she's immune?
Because if a woman contracts rubella during the first trimester, the virus crosses the placenta and causes devastating congenital anomalies, deafness, cataracts, severe heart defects. If her titer shows she is not immune, we cannot give her the vaccine while pregnant, but we know to counsel her aggressively on avoiding sick individuals, and we plan to vaccinate her immediately postpartum.
We also do a clean catch urinalysis to check for baseline protein, glucose, and asymptomatic bacteriuria. We do a pap test for cervical cancer screening, and then we aggressively screen for sexually transmitted infections, gonorrhea, chlamydia, syphilis using an RPR test, HIV, and hepatitis B and C.
This is non-negotiable. Let's take syphilis as an example. Why screen for it? Because the Treponema pallidum spirochete can easily cross the placenta.
And what happens if it does?
If a mother has untreated syphilis, it can cause late-term miscarriage, stillbirth, or severe congenital syphilis in the newborn, leading to bone deformities and neurological damage.
But if we catch it at week 8 during this intake,
we simply treat her with penicillin. The infection is cured, the baby is protected, disaster averted. The same logic applies to HIV. If we identify an HIV-positive mother early, we can start her on antiretroviral therapy. We can lower her viral load to undetectable levels, plan for a cesarean birth if necessary, and treat the infant postpartum. We can drop the transmission rate from 25% down to less than 1%.
Less than 1%.
Yes, but we can only perform these miracles if we test for the risks early.
The intake visit literally alters destiny. Okay, so the baseline is set. Let's move into how we monitor the pregnancy over time. We are talking about follow-up visits and fetal assessment.
Right. At every follow-up visit, we're looking for deviations from the expected trajectory. One of the most classic, low-tech, high-yield assessments is measuring fundal height.
The nurse essentially takes a flexible measuring tape and measures the mother's growing abdomen. The rule of thumb is that between 18 and 30 weeks, the height of the fundus, measured in centimeters, should perfectly match the weeks of gestation, plus or minus 2 weeks. So if she is 24 weeks pregnant, her fundal height should measure right around 24 centimeters.
Yes. The anatomical landmarks are crucial. You place the 0 mark of the tape at the upper border of the symphysis pubis, the pelvic bone, and stretch it over the curve of the belly to the upper border of the fundus, which is the top of the uterus. But there is a massive physiological caveat that can ruin your data.
The bladder.
The bladder must be completely empty before you measure.
Why?
Think about the anatomy. The bladder sits right in front of the lower uterus. If the bladder is full of urine, it inflates like a balloon and physically pushes the entire uterus upward and outward. A full bladder can artificially increase your fundal height measurement by as much as 3 full centimeters.
So you measure 27 centimeters on a 24-week pregnant woman, you panic, you order expensive ultrasounds, and it turns out she just really needed to pee.
Exactly. So, assuming the bladder is empty, how do we use this data for clinical reasoning? What if she is 28 weeks pregnant, but she consistently measures at 24 centimeters?
Well, a stable or decreased fundal height that is falling behind the expected curve is a glaring red flag for intrauterine growth restriction, or IUGR. The baby isn't growing.
Right. It suggests placental insufficiency. The baby isn't getting enough nutrients or oxygen. Conversely, what if she's 24 weeks pregnant but measures 30 centimeters?
An excessive increase means the uterus is too big. This suggests either a multiple gestation surprise, it's twins, or it suggests polyhydramnios, which is a pathological excess of amniotic fluid. Either way, any abnormal fundal height measurement immediately prompts the provider to order an ultrasound to visualize exactly what is going on inside.
Precisely.
Now, here is a critical safety point. When the nurse is measuring that fundal height, the patient is lying flat on her back on the examination table. The clinical guidelines feature a massive red emergency alert box regarding this exact position: supine hypotension.
This is one of the most classic physiological traps in all of obstetrics. It is a brilliant example of how anatomy and physics collide.
Let's dissect it. What is happening inside her body?
When a pregnant woman, particularly in her 2nd or 3rd trimester, lies completely flat on her back, the supine position, the heavy gravid uterus, along with the baby, the placenta, and the fluid, all fall backward due to gravity.
Okay, falling backward onto what?
This massive weight lands directly on top of the inferior vena cava and the descending aorta, which run right along the spine.
So she is lying flat, and her own uterus is basically pinching off the main vein that returns deoxygenated blood from her lower body back to her heart.
It acts like a tourniquet. Because venous return to the right atrium is drastically cut off, cardiac output plummets. When cardiac output drops, her systemic blood pressure crashes. This is supine hypotension.
And what does that look like clinically?
The patient will suddenly turn very pale. She will complain of dizziness, faintness, or breathlessness. Her heart rate will spike tachycardia as her body desperately tries to compensate for the lack of blood. She might feel nauseous, and her skin will turn cold and clammy.
So a completely routine exam on a flat table can literally induce a medical emergency where the mother passes out and the baby is deprived of oxygen.
It happens all the time. But this is where elegant, simple nursing interventions save the day. If this happens, your immediate intervention is not to hit the blue button or push IV drugs. Your intervention is gravity.
You simply turn the woman onto her side.
Specifically, the left lateral side is best, as it completely rolls the heavy uterus off the vena cava. Venous return is instantly restored, cardiac output normalizes, and the symptoms vanish in seconds.
The text also notes a preventative trick. Before you even start an abdominal exam, you place a small rolled towel or a wedge under her right hip. That slight tilt is enough to keep the uterus displaced off the vessels while still allowing you to measure the fundus. It's such a simple structural fix to a massive physiological threat.
It really is. Let's move on to other follow-up assessments. We monitor fetal heart tones with a Doppler at every visit, counting the rate for a full minute. We verify that maternal perception of fetal movement is continuing. Around 18 to 22 weeks, she will have a comprehensive ultrasound for a full fetal anatomy scan.
We also have specific follow-up labs. She gives a clean catch urine sample at every single visit to check for glucose, protein, and nitrites, which screen for gestational diabetes, preeclampsia, and urinary tract infections, respectively. Then we have time tests. Between 24 and 28 weeks, we do the 1-hour glucose tolerance test.
Right, the GTT screens for gestational diabetes. Pregnancy hormones naturally create a state of insulin resistance to ensure plenty of glucose stays in the blood for the baby. But if the mother's pancreas can't keep up with the increased demand for insulin, her blood sugar spikes.
And at 36 to 37 weeks, we perform vaginal and rectal swabs to screen for group B streptococcus, or GBS. Now, I have to ask, GBS can cause lethal sepsis or meningitis in a newborn. Why on earth do we wait all the way until week 36 to check for it? Why not do it at the intake visit with everything else?
Because GBS is a transient flora. It comes and goes in the human body. A woman could test completely negative at week 10, but be heavily colonized at week 38. Conversely, she could be positive early on and negative later.
So early testing is useless.
Exactly. The bacteria only poses a threat to the baby during the actual birth process, when the infant passes through the colonized birth canal and aspirates the fluid. Therefore, we wait until the very end. A swab at 36 to 37 weeks provides the most accurate, up-to-date prediction of whether she will be colonized at the time of labor.
So what happens if she's positive?
If she's positive, we don't treat her with oral pills. Then we wait until labor begins, and we run IV antibiotics continuously to protect the baby as it descends.
Let's talk about genetic screening. Early in the pregnancy, we can offer cfDNA cell-free DNA testing, which looks at fragments of fetal DNA floating in the mother's bloodstream. In the second trimester, we offer the maternal serum alpha-fetoprotein test, the MSAFP. How does drawing the mother's blood tell us if the baby has a spinal defect? What is the mechanism there?
It's brilliant biological detective work. Alpha-fetoprotein is a protein produced by the fetal liver. Normally, a small, predictable amount crosses the placenta into the mother's blood. However, if the fetus has an open neural tube defect, like spina bifida, where the spine hasn't closed properly, or an anencephaly, the fetal spinal fluid literally leaks large amounts of this protein out into the amniotic fluid.
And that excess protein then diffuses across the placenta
Into the maternal circulation. So if we draw the mother's blood and the MSAFP levels are abnormally high, it's a glaring red flag that there is a leak in the fetus's neural tube. Conversely, abnormally low levels are associated with chromosomal abnormalities like Down syndrome.
The logical flow of all this monitoring is incredible. The fundal height screens for growth issues, the MSAFP screens for structural defects, the GBS swab dictates our IV protocols during labor. Every single piece of data is a brick in the road building toward a safe delivery.
Which brings us perfectly to education. Assessing the patient is only half the job. The other half is empowering the patient with knowledge. We have to teach them self-management.
Let's start with physical activity. The guidelines recommend 150 minutes of moderate intensity aerobic activity each week, but there are caveats.
Obviously, avoid contact sports, avoid scuba diving due to pressure changes, avoid activities requiring precise balance like gymnastics or horseback riding, because the massive shift in a pregnant woman's center of gravity makes falls highly likely.
And absolutely avoid the Valsalva maneuver.
Yes. Holding your breath and bearing down hard, like during heavy weightlifting spikes, intrathoracic pressure, and can dangerously drop cardiac output and placental blood flow.
The literature includes a clinical case study here about a 29-year-old pregnant woman who was a competitive long-distance runner in college and wants to stay fit. The critical thinking question asks what nursing education is indicated versus contraindicated.
Right. It is indicated to ask her to deeply describe her current exercise routine. If she has been running 5 miles a day for years, her body is adapted to it and she can likely continue a modified version. But it is contraindicated to allow her to suddenly start training for a marathon if she hasn't run in 5 years.
And it is strictly contraindicated to tell her the old myth that she needs to be eating for 2.
Yes. Eating for 2 implies doubling your caloric intake, which leads to excessive, dangerous weight gain. She only needs about 300 to 400 extra calories a day in the later trimesters. Thermoregulation is also vital during exercise. Drink water, avoid overheating, and stay out of hot tubs or saunas, as maternal hyperthermia is linked to neural tube defects.
Let's discuss immunizations. The clinical guidelines have a massive safety alert here, and no live vaccines during pregnancy, period.
Live attenuated vaccines, like the measles, mumps, and rubella, or MMR vaccine, or the varicella or chickenpox vaccine, contain a weakened but still living version of the virus. Because the mother's immune system is naturally slightly suppressed during pregnancy, there is a theoretical risk that the live virus could cross the placenta and cause teratogenic effects, meaning birth defects.
But inactivated vaccines, where the virus is completely dead, are safe and highly recommended, like the seasonal flu shot and the COVID-19 vaccine. And then there is the Tdap vaccine. tetanus, diphtheria, and pertussis, which is whooping cough. The protocol states you must give the Tdap between 27 and 36 weeks of every single pregnancy. Why are we so incredibly specific about that timing?
This is one of my favorite pieces of maternal fetal immunology. We are not giving the Tdap just to protect the mother. Whooping cough is an absolute killer of newborn infants, but infants cannot get their own pertussis vaccine until they are 2 months old. That leaves a terrifying 8-week window where they are defenseless.
So how do we protect them?
We vaccinate the mother in the late second or early third trimester. This provokes her immune system to generate a massive army of specific IgG antibodies. Because IgG antibodies are small enough to cross the placenta, that maternal army marches across into the fetal bloodstream.
It builds a bridge of passive immunity.
Exactly. The baby is born preloaded with the mother's antibodies, protecting them during those vulnerable first months. But here is the catch. Maternal antibodies degrade rapidly. They don't last forever. So if she gets pregnant again 2 years later, she has to get the shot again to build a fresh army of antibodies for that specific baby.
That is awe-inspiring. And speaking of antibodies, we absolutely have to dissect Rh immune globulin, commonly known as RhoGAM. This is a routine injection given around 28 weeks.
But it is only given to mothers who have an Rh-negative blood type. Let's explain the physiology of the Rh factor, because it's essentially an immune system war.
Right. Blood types have a positive or negative designation, like A positive or O negative. That positive or negative refers to the presence of the Rh antigen, a specific protein on the surface of the red blood cells. If you have the protein, you are positive. If you lack it, you are negative.
Now, imagine an Rh-negative mother is carrying an Rh-positive baby. The baby inherited the positive gene from the father. Usually, maternal and fetal blood do not mix. But during trauma, amniocentesis, or simply during the birthing process, a few drops of the baby's Rh-positive blood will inevitably mix into the mother's bloodstream.
And the mother's immune system, which has never seen this Rh protein before, recognizes it as a dangerous foreign invader.
Exactly. Her immune system sounds the alarm and builds antibodies specifically designed to hunt down and destroy Rh-positive red blood cells. This process is called alloimmunization or sensitization.
Now, this usually isn't a huge problem for the first baby because by the time the mother builds the antibody army, the first baby has already been born.
But it is a catastrophic problem for the next pregnancy. If she gets pregnant with a second Rh-positive baby, her immune system still has those antibodies waiting. Those antibodies will cross the placenta, attack the new fetus, and destroy its red blood cells. This causes profound fetal anemia, heart failure, and often death, a condition called hemolytic disease of the newborn.
So how do we stop this immunological war?
We give the mother a shot of Rh immune globulin at 28 weeks and again within 72 hours after birth. This shot is essentially a stealth team of synthetic antibodies. They patrol the mother's bloodstream, find any stray fetal Rh-positive cells, and quietly destroy them before the mother's own immune system ever notices they are there.
If the mother's immune system never sees the fetal cells, it never builds the attack antibodies. We blindfold her immune system to protect the next baby. Science is just wild.
It is brilliant. Let's touch on some other self-management topics. We teach Kegel exercises to strengthen the pelvic floor muscles, preventing urinary incontinence. We teach proper posture to alleviate lower back pain.
The guidelines show how to relieve those brutal middle-of-the-night calf cramps. You dorsiflex the foot, pulling the toes hard back toward the knee rather than pointing them. We teach safe travel. When wearing a seatbelt, the lap belt must be positioned low under the gravid abdomen, resting across the strong pelvic bones, never across the soft belly.
What about dental health?
Oh, I remember an old wives' tale my grandmother used to say. For every child, a tooth. The implication was that the growing baby literally sucks the calcium right out of the mother's teeth to build its own skeleton, causing the mother's teeth to rot and fall out.
It's a persistent myth, but it's entirely false. Calcium is fixed in the enamel of adult teeth. It cannot be mobilized and drawn out by the fetus. However, there is a core of truth regarding dental danger. Pregnancy hormones, specifically estrogen, cause increased vascularity and swelling in the gums. This makes them highly susceptible to bleeding and infection pregnancy gingivitis.
But if my gums are bleeding, how does that affect the baby?
Because advanced periodontal disease is a massive bacterial infection, the immune system fights this infection by releasing inflammatory markers called prostaglandins. Prostaglandins are the exact same hormones the body uses to ripen the cervix and trigger uterine contractions. Extensive research links severe periodontal disease with a highly increased risk of preterm birth, preeclampsia, and low birth weight.
So an oral health assessment and referring your patient to a dentist is literally a nursing intervention to prevent premature labor. I love how everything is interconnected.
Finally, we must discuss sexuality. Patients are often terrified to ask, but the clinical teaching states that vaginal penetration and orgasm are generally perfectly safe throughout the entire pregnancy.
Unless there are specific medical contraindications, like unexplained bleeding, cramping, ruptured membranes, or a known high risk of preterm labor.
Right. Open, non-judgmental communication is key here. The nurse's job is to proactively dispel myths, suggest comfortable alternative positions as the belly grows, and ensure that women who are at risk for STIs understand they must continue to use condoms.
All right, taking a deep breath, we are moving into the absolute core of clinical reasoning. We have to discuss normal discomforts versus potential complications. As a nurse, you will get phone calls every single day from terrified pregnant women experiencing weird symptoms. Your job is to triage. You have to differentiate the expected, annoying physiological aches of pregnancy from the red flags of impending disaster.
Let's break down the normal discomforts first and map them to their physiological causes. In the first trimester, the classic symptom is nausea and vomiting, commonly called morning sickness, though it can strike at 8 p.m. just as easily.
What causes it?
The exact mechanism isn't fully understood, but it is strongly correlated with the rapid rise in HCG and estrogen levels, alongside changes in carbohydrate metabolism. Nursing interventions. Eat dry carbohydrates like crackers immediately upon waking before even getting out of bed. Eat 5 or 6 small meals rather than 3 large ones. Avoid greasy, highly seasoned foods.
Patients also complain of intense breast tenderness.
That is caused by glandular hypertrophy and increased vascularity as the breasts prepare for lactation. The intervention is simple. Wear a highly supportive, well-fitting bra, even at night.
We also see a lot of urinary urgency and frequency in the first trimester. The growing uterus is still sitting low in the pelvis, pressing directly against the bladder, and leukorrhea, an abundant white mucoid vaginal discharge.
Leukorrhea is caused by high estrogen levels stimulating the cervix to produce mucus. It's entirely normal and forms the mucus plug that seals the cervix. The teaching is, wear a cotton pad, wipe front to back, but under no circumstances should you ever douche, as it alters the vaginal pH and invites infection.
Moving to the second trimester, we encounter the effects of progesterone. I feel like progesterone is the ultimate frenemy of pregnancy.
That is highly accurate. Progesterone is the vital hormone that maintains the pregnancy. One of its primary mechanisms is relaxing smooth muscle tissue,
which is fantastic for keeping the smooth muscle of the uterus relaxed, preventing it from cramping and expelling the baby prematurely.
Yes, but the gastrointestinal tract is also made of smooth muscle. Progesterone doesn't discriminate. It relaxes the cardiac sphincter at the top of the stomach, allowing stomach acid to easily splash back up into the esophagus, causing brutal acid reflux and heartburn.
And it relaxes the smooth muscle of the intestines, drastically slowing down peristalsis.
When food moves sluggishly through the colon, the body has more time to absorb water out of the stool. The result: rock-hard stool, severe constipation, and painful flatulence. The nursing interventions are entirely dietary. Eat small meals, sit upright for 30 minutes after eating to prevent reflux, drink at least 2 liters of water a day, and heavily increase dietary fiber to force the bowel to move.
Also in the second trimester, women complain of a sharp stabbing pain in their lower abdomen or groin when they stand up quickly or roll over. This is round ligament pain.
The uterus is anchored to the pelvis by the round ligaments. As the uterus rapidly grows, these ligaments are stretched tight like rubber bands. Sudden movements cause them to spasm. The intervention is teaching the patient to move slowly or to assume a squatting position or bring her knees to her chest to release the tension on the ligaments.
In the third trimester, the sheer mechanical size of the baby causes chaos.
The uterus is so massive it physically pushes the diaphragm upward by about 4 centimeters. The lungs cannot fully expand, causing constant shortness of breath. Interventions include practicing good posture and sleeping propped up on several extra pillows.
The heavy uterus also compresses the pelvic veins, impairing venous return from the lower body,
which leads to dependent, non-pitting ankle edema, varicose veins in the legs, and hemorrhoids in the rectum. The primary intervention is frequent elevation of the legs above the level of the heart to let gravity assist the blood flow.
We also see Braxton Hicks contractions. These are irregular, painless practice contractions.
The intervention for Braxton Hicks is to rest, change physical positions, and drink a large glass of water. If they fade away, they're normal. But this perfectly transitions us to the dark side: potential complications. How does a nurse use this knowledge to triage?
Because patient education is your best triage tool. You teach them these specific warning signs so they know exactly when to bypass the clinic and go straight to the hospital.
Let's run scenarios. A patient calls in the first trimester. She says she has been vomiting so severely she cannot keep water down for 24 hours and she is losing weight.
That is not normal morning sickness. That is hyperemesis gravidarum. She needs IV fluids and antiemetics to prevent severe dehydration and electrolyte imbalances.
What if she calls in the first trimester complaining of severe localized abdominal cramping accompanied by bright red vaginal bleeding?
That is not round ligament pain. That is a glaring sign of a potential miscarriage, or worse, a ruptured ectopic pregnancy, which is a life-threatening hemorrhagic emergency.
What if she calls complaining of chills, a fever over 101, and severe burning when she urinates?
That is not normal urinary frequency. That is an ascending urinary tract infection or pyelonephritis, which can trigger preterm labor if untreated.
Let's move to the later trimesters. She calls and says there was a sudden, uncontrollable gush of watery fluid from her vagina at 32 weeks.
That is not leukorrhea or a stress incontinence urine leak. That is PPROM, preterm, pre-labor rupture of membranes. Her water broke prematurely, exposing the fetus to massive infection risk.
She calls and says she's having rhythmic, painful pelvic pressure and cramps that are coming every 10 minutes, and she is only 34 weeks.
Those are not Braxton Hicks practice contractions because they are rhythmic and not going away with rest. That is active preterm labor.
She calls and says the baby hasn't moved at all today.
An absence of fetal movement is a massive immediate red flag for severe fetal distress or intrauterine fetal demise. She needs a non-stress test immediately.
Let's do the hardest one. A patient calls at 36 weeks and says, I have a terrible headache. In our list of normal discomforts, headaches are actually listed as normal, caused by emotional tension, sinus congestion, or eye strain. But in the warning signs list, headaches are a cardinal sign of preeclampsia. How do you, the nurse on the phone, figure out which one it is?
This requires intense clinical reasoning. You don't just say, take Tylenol. You ask targeted questions. You ask about the quality of hora. A preeclampsia headache is usually described as throbbing, severe, continuous, and the worst headache of my life. Does it feel like that, or does it feel like a dull tension ache?
Excellent. What else do you ask?
You ask about accompanying systemic signs of vasospasm. Are you having any visual disturbances? Are your eyes blurry? Are you seeing flashing spots or ortis?
Because the vasospasm of preeclampsia affects the blood vessels in the retina and the brain.
You ask, have your hands and face suddenly puffed up and swollen today?
Because preeclampsia causes fluid to leak out of the vascular space into the tissues.
And crucially, you ask, do you have any sharp, severe pain in your upper right abdomen right up under your ribs?
Because that indicates the liver is swelling inside its capsule due to the disease process.
If she answers yes to those questions, you do not tell her to rest. You tell her to come to the hospital immediately, because that is preeclampsia until proven otherwise, and she is at risk of a seizure. That right there is the difference between blindly reading a textbook and actually thinking like a nurse.
Exactly. You're synthesizing data to prevent catastrophes.
Let's move into our final area. Variations in care, perinatal education, and planning for birth. We have to adapt all of this standardized care to specific high-risk populations. The clinical literature uses a fantastic unfolding case study to highlight adolescent pregnancy.
Adolescents represent a deeply vulnerable, high-risk population. Developmentally, they are still children themselves. They frequently enter prenatal care very late, often well into the second trimester, due to sheer denial, fear of telling their parents, or lack of transportation. Physiologically, they are at a statistically higher risk for developing preeclampsia, delivering low birth weight infants, and suffering from severe anemia because their own growing bodies are competing with the fetus for nutrients.
In the case study, we meet a 16-year-old named Monica. The nurse first has to recognize her immense knowledge deficits. She literally does not know how a pregnancy works or what to expect. Later in the study, Monica skips a crucial prenatal appointment. When the nurse calls her, Monica says she feels fine, she wanted to go out of town with friends, and besides, she hates getting her blood drawn.
The nurse has to intervene carefully here. You cannot scold her like a parent. You have to explain in language she understands that skipping care directly increases the risks of dangerous complications like preterm birth, which could land her baby in the NICU for months.
The final, most heartbreaking part of the case study addresses social isolation. Monica reveals that her friends have stopped calling her because she can't go to parties. Her boyfriend is ignoring the situation to focus on high school football. And her mother is furious and unsympathetic.
The critical nursing action in this moment is not medical. It's profoundly psychosocial. You cannot prescribe a pill for loneliness. The nurse must provide active referrals to adolescent peer support groups and specialized parenting classes that are appropriate for her developmental stage. You have to actively build a support network to decrease that isolation. You're treating the social determinants of health, not just the physical body.
On the complete opposite end of the demographic spectrum, we have advanced maternal age, defining women over the age of 35.
While the vast majority of these women have perfectly healthy pregnancies, the physiological reality is that advanced age increases the statistical risk for genetic chromosomal disorders. It also drastically increases the likelihood of pre-existing medical conditions, like chronic hypertension or type 2 diabetes complicating the pregnancy. Furthermore, there is a notably higher rate of cesarean births in this demographic.
The care plan shifts here. It requires more frequent visits, early genetic counseling, and highly intensified fetal monitoring as they approach term.
And then we must consider multifetal pregnancy, twins, triplets, or more. Everything we have discussed today is amplified in a multiple gestation.
The mother's blood volume expands even more massively, putting immense strain on her cardiovascular system. The risk of preterm birth skyrockets because the uterus is stretched to its absolute physical limits much earlier. The risk of intrauterine growth restriction is high because the fetuses are competing for placental real estate.
And, crucially, it introduces profound, devastating ethical dilemmas that the nurse must navigate. With higher-order multiples, say, quadruplets, the medical team may counsel the parents regarding selective reduction.
Meaning terminating one or two of the fetuses to improve the survival chances and prevent extreme prematurity for the remaining fetuses.
Yes, it is an agonizing decision. It requires immense, entirely non-judgmental, hypersensitive nursing support. The nurse must hold space for their grief, regardless of the choice they make. With age variations and multifetal pregnancies, the nurse must seamlessly shift from being a routine educator to a high-risk, intensive case manager.
As we near the end of the pregnancy journey, the focus of perinatal education shifts from maintaining the pregnancy to the main event, planning for birth. Let's look at the options for birth settings because the landscape has changed.
The most common setting is the traditional hospital room, but these have largely transitioned into LDR or LDRP rooms, standing for labor, delivery, recovery, and postpartum.
The text shows pictures of these. They look like comfortable, upscale hotel rooms with wood paneling and nice beds. But hidden behind the artwork and the cabinetry is full, high-tech emergency resuscitation equipment, oxygen lines, and infant warmers. It blends comfort with immediate safety.
Then you have freestanding birth centers. These are typically staffed by certified nurse midwives. They offer a deeply home-like, low-intervention environment, but they are strictly reserved for women who are completely low risk. If an emergency develops, the patient must be transferred to a hospital.
And finally, home birth. The literature notes this is a controversial but steadily rising choice. The American College of Obstetricians and Gynecologists clearly states that the safest place to give birth is a hospital or accredited birth center, but they respect the woman's autonomy to choose. However, there are absolute medical contraindications for attempting a home birth.
A provider will not agree to a home birth if there is fetal malpresentation, like a breech baby. They will not do it for multiple gestations. And they will strongly advise against it if the mother has had a prior cesarean birth due to the risk of uterine rupture.
The chapter also heavily discusses the role of the labor doula. This is not a medical professional. It's a trained professional who provides continuous physical, emotional, and informational support to the mother before, during, and just after birth.
And the evidence supporting doula care is overwhelming. Research consistently shows that continuous one-on-one support by a doula leads to statistically shorter labors, a decreased use of epidural anesthesia or pain medications, and a significantly higher likelihood of a spontaneous vaginal birth without the need for vacuums, forceps, or cesareans.
All of these choices, the setting, the team, the pain management preferences, funnel into a document called the birth plan. It's a communication tool where parents explicitly list their desires for how the labor will go.
But I deeply appreciate how the clinical textbook frames this concept to nursing students. A birth plan must be viewed by both the nurse and the patient as a preference list based on a best-case scenario.
I have to ask about this because you hear horror stories on the floor. What happens when a nurse gets a patient with an incredibly rigid, militant birth plan that demands things that suddenly become medically unsafe as the labor progresses?
It is arguably one of the hardest parts of intrapartum nursing. You have two competing mandates: honor the patient's autonomy and keep the mother and baby alive.
How do you handle a rigid plan in a dynamic, crashing medical emergency?
The work starts the moment you meet them in triage. You establish trust immediately. You praise their preparation. But you also gently lay the groundwork for flexibility. When an emergency does arise, your role is ongoing, informed consent. You don't just run into the room and start doing things against their plan. You clearly communicate the why. You say, your birth plan explicitly says no continuous electronic fetal monitoring. I hear that. But the baby's heart rate just dipped dangerously low on the Doppler, and here is exactly why we need to change the plan right now and put the monitors on to keep your baby safe. It requires immense flexibility from the patient, but that flexibility is only possible if it is built on a foundation of absolute trust created by the nurse.
Wow. We've covered an astronomical amount of ground today. We started with the murky diagnostics of presumptive, probable, and positive signs. We calculated due dates while fighting leap years. We navigated the psychological tidal waves of maternal and partner adaptation. We unpacked the massive initial intake, analyzed the hidden dangers in routine labs, measured fundal heights, triaged preeclampsia versus normal headaches, and planned the birth.
But look at what we've done. If you can connect the dots, if you can actually see why progesterone causes brutal constipation, or why crossing your legs alters intrathoracic pressure, or why the Tdap vaccine builds an immunological bridge for the newborn, it isn't just a dry list of textbook facts anymore. It is a logical, beautiful roadmap of human physiology.
To bring it all back to our very first thought, we talked about how diagnosing and managing pregnancy isn't like looking at a clean binary X-ray of a broken bone. It is not a single isolated event in time. It is a messy, dynamic, terrifying, and beautiful landscape. The medical textbook gives you the coordinates, but as the nurse, you are the expert guide walking the patient through that perilous landscape.
And I want to leave you, our listener, with a final, provocative thought to mull over. We spent a lot of time discussing Reva Rubin's phases of maternal adaptation, arriving at that crucial phase 3, I am going to be a mother. But the psychological concept of maternal identity does not just happen and magically finish the moment the baby is born. It continues to evolve and solidify for months and years afterward.
That's a huge point.
Consider this. How does the quality of your specific communication as a nurse during these 40 weeks impact that identity? The way you validate a mother's embarrassing fears, the way you answer her questions without ever making her feel silly, the way you empower her to trust her own body. How does your nursing care shape her confidence in herself as a parent for the rest of her life? You are not just taking vital signs and checking urine, you are actively building parents.
What an incredibly powerful perspective to carry into the hospital. To the nursing student listening to this on your commute or pacing your room right before your clinical rotation, you have got this. Take a deep breath. Stop trying to memorize blind facts. Keep connecting those physiological dots between the textbook pages and the living, breathing, vulnerable patient sitting in front of you. Thank you for joining us for this deep dive. From all of us at the Last Minute Lecture Team, study hard, trust your knowledge, and we will see you on the floor.